This is the second of 15 short videos that I hope will give you a grounding in the pediatric education that we would expect any students to have before they start seeing children as a professional qualified clinician. In the first video, I talked about some of the things that are different about children, and I would like you to reflect on these differences. I described some of the changes in terms of anatomy, physiology, normal ranges, growth, neurodevelopment, and the relationship with the person that they come with, namely their carer or parent, and how this changes as the child goes through early childhood and into adulthood. I asked you to think about some of the safeguarding issues that might arise and how we might need to communicate with children and carers to try and get a useful child-focused history and examination with further investigations to start initiating treatment. I asked you to think a little bit about some of the conditions that might present in childhood as opposed to adulthood, and how they might present and how the differential diagnosis of any sign or symptom result will change as the child gets older. I'm hoping that since you watched the first video, you've had a chance to reflect on some of these things and have had a look at a child's growth chart and thought a bit more about growth as I described in the first video. I'm also hoping that you've started to think about how you're going to structure your learning and reading and the rest of your clinical attachment to extract the most you can from this very short period that you have with us in pediatrics. In this talk, I would like to focus specifically on how we take the history from a child who is under 1 year of age. The first year of life or infancy is a particularly important time for us as clinicians looking after children. There is a massive change that happens in the first year of life. A child will go from being 2.5 to 3.5 kilograms in weight to up to 10 kilograms in weight over a short 12-month period. During that time, they will go from being completely dependent with very little that they can do spontaneously on their own through a child who might be able to walk, will be starting to say some syllables, will start to pick up objects with a thumb and forefinger, and will really be starting to become the incredibly complex adult that they were born to be. During this first year of life, many things can go wrong, and our job as clinicians to think about what those things might be. Broadly, we would think about those in terms of congenital problems and acquired problems. Now, this is a very challenging thing to think about because we will see congenital problems, in other words, conditions that children are born with, that they might have acquired in the womb or might have acquired in the first few hours or days of life. And I will talk about this specifically when we talk about the neonatal period. But if we think about congenital problems as the sorts of things that a child might be born with, as opposed to the acquired problems that we might start seeing in the first year of life, this is also complicated because many of the seemingly new or acquired issues might actually have a genetic basis. And this might be the first time that a child presents with their epilepsy syndrome or with their neurodevelopmental syndrome or their neurometabolic problem. All of these were part of the child's genetics, but will present in the first year of life, and we have to have a structured approach to how we take the history. Clearly, the child is not able to give a history, and we are entirely dependent on the adult who's giving that history. That adult needs to give us the relevant information, but will come to us with their own background, ideas, concerns, expectations, and ideas about how health works. They might have prejudices about doctors or about healthcare systems. They may have ideas about what causes illness that don't really fit with our medical model. And part of our skill in taking a history in the first year of life is to try and help carers to give the information that we need in a way that we can process. This needs to be done carefully and patiently and kindly. And my general rule of thumb is to say that a parent's job is to worry about their child, and our job is to try and work out how worried they should be. This is not the same as dismissing their concerns. A concerned parent should always be listened to very carefully and respectfully, and their concerns discussed in detail If not, they will never be satisfied with the consultation, and they will keep coming back for the concerns, and they will never be happy with how their child is being cared for, because their job is literally to make sure that their child is healthy and well. The parent is walking a tightrope between being over anxious and negligent. And as a parent, we are always trying to make sure that we are walking this tightrope to the best of our ability. Some parents are very good at this. Some parents are less good at this for all sorts of reasons. And our job is to try and walk this little bit of their parenting journey with them kindly and respectfully, using an approach that is child and family centered. If we don't do this, we are no good to the child and that family, and we need to step away and get somebody else to do the job, because we're not doing our job. Our job is to try and make people's lives better by listening to them and addressing their concerns to the best of our ability, or getting the appropriate people involved who can help this family. When we're thinking about the history, it has to be profoundly different, because the first few months of this child's life obviously happened whilst they were in the womb. And therefore, we have to have a structured approach to thinking about the pregnancy and medical, social, or other practical problems during the pregnancy that might have affected that child's well-being. This might be maternal substance misuse or maternal medications for various physical or mental health problems. It might be illnesses such as diabetes, or acquired problems such as infection, or it might be other things that went on during the pregnancy that will have an impact on the child's health and well-being. We have to have a way of thinking about the monitoring that happened during pregnancy, and then we have to have a structured approach to thinking about the labor and the delivery. We need to know whether the child was born on time, whether they were premature or overdue. Was this a spontaneous natural delivery, or was it induced, or was it a cesarean section, or was it assisted? Were there any complications through the labor, or were there any complications during the delivery? And it is really important that we can take a structured history that allows us to understand this. I'll talk more about this when we talk about the neonatal history, but it is important that we understand briefly the child's journey up until the point of discharge into the community from where they were born, whether it was a birth center or a hospital, or if indeed they were born at home, whether any other follow-up was required. We've then got to think about what is important and different about the first year of life. We have to know this child's structured family history and social history, because they're entirely dependent upon this. We need to know who is at home, who do they live with, who provides care, who is involved in their care on a daily and weekly basis. We need to know if there are any other social issues, or if there's anything else going on at home that might impact on that child's well-being or safety or ability to thrive. This would include social concerns such as mental health problems, or if there is a history of domestic violence or a previous history of social services involvement. And we have to find a kind and sensitive but thorough way of asking these questions. And you need to watch the team and listen to how they ask these questions on the ward in a way that is helpful but doesn't sound prejudiced or rude. We need to have an understanding of the other things that we monitor as the child goes through the first year of life. Specifically, we have to have a structured approach to thinking about their neurodevelopment, thinking about their growth, as described in the first video, and thinking about other screening tests, such as health visitor screening tests, hearing tests, the heel prick that we do at a week of age, whether they needed any other additional screening, such as hip screening if there were risk factors for hip problems. And so we have to have a way of thinking about these routine screening and monitoring involvement that all children should be getting in our society. We've also got to have a way of thinking about some of the other things that we do to children routinely to try and keep them healthy and safe and well. Therefore, we have to have a way of thinking about their immunization history. We have to have a way of thinking about whether there is anything else that has been put in place for that child because of other health, social, or neurological problems. It may be that they're already under a pediatrician for something. It may be that they are already on treatments or have demonstrated some allergies problems, or there are other concerns that we need to be aware of. We have to have a kind and structured way of asking these questions that's actually very, very different from thinking about an adult. And therefore, for this session, the key thing I want you to think about is that structured, rigorous approach to the first year of life and how we're going to ask these questions. How we're going to ask about the pregnancy, the labor, the delivery, and the neonatal period. How we're going to ask about routine screening that would include hearing tests, hip checks for some children, how we would think about the newborn baby check, the 6-week check, and the health visitor check, how we would think about their growth, their development, and their immunization history, as well as then considering their social and family history and the context in which that child is being raised and looked after. This is not something that you can just learn from a book. You have to have practical experience, both of watching skilled clinicians take care history, but also doing it. And you cannot be signed off for a pediatric attachment without taking a structured, thorough pediatric history in an under 1-year-old and presenting your findings and discussing them with a senior clinician.